was that the 5 past about that on my watch?
Perfect. Okay. Just sitting on someone's. Great. Okay guys, so for any of you who are not familiar with this, I see a lot of you are commenting, which is great. Throughout, we're gonna do about a little 15-minute intro session. We're gonna talk about Dr. Huang's work. And then at any point, if you guys have any questions or comments or something just really doesn't make sense, just comment, you can react. You can let us know if you want us to repeat anything, okay? So I'm gonna be looking through the chat the whole time. So if there's ever anything, please let us know.
All right. Melissa? Okay, thank you, Melissa. So welcome everybody to this Facebook Live presentation from the Research Institute of McGill University Health Centre here in sunny Montreal, having a bit of good weather for a while. So those of you who don't know me, my name is William Foulkes and I'm a Professor of Human Genetics at McGill University. I'm also a medical geneticist looking after people at high risk or have developed hereditary forms of cancer. And it was through that work that some years ago, about 10 years ago now almost, we identified the gene SMARCA4 that is the cause of small cell cancer of the ovary hypercalcemic type, or SCOOT or SCOTT, or you can choose your preferred acronym. I tend to call it SCOOT, but I guess you can choose. I'm just not going to say small cell cancer of the carcinoma of the ovary hypercalcemic type 10 times, because you can see why it gets a bit tongue-tied. So that disease, as many of you will know, affects primarily young women with a median age of about 24 years old. And the fact that it's caused by a single gene, there's virtually no other causes, apart from maybe a few cases caused by SMARCB1, which is like a partner gene. That means that we have extraordinary opportunities for targeting this tumour, because there's only really one cause. When you have 20 causes, you need 20 different approaches, whereas here we only have one. So today, as part of a series run by the Research Institute, myself and others, as part of the registry, the SCOOHT-SMARCA4 registry, which we set up some years ago, I'm doing a number of sort of one-on-one chats with prominent people working in the field of small cell cancer of the ovary. So today I'm with Dr. Sidong Huang, who's a tenured associate professor of biochemistry at McGill University, a close colleague of mine, and he's here to tell you about some of his exciting work that's come out in the last sort of 5 or 6 years in this area. So maybe Sid, can you tell us about your work and what kind of approach you've been using most recently?
Sure, Will. Well, thank you for the introduction, the opportunity to share some of my work. And as Will said, SCOOH is really interesting disease in the sense that only caused by single gene inactivation. So we thought the approach we try to take is use a systematic genetics approach where we can inactivate gene one by one in the tumor cells to see which gene upon inactivation can selectively kill the SCOOH cells but not the normal cells. So that's the approach we've taken, and complementary to that, we can also perform a drug screen using existing drugs that have been approved to treat other type of cancers or disease, and try to find which drugs we can repurpose to treat SCOOH, right?
So let's start with the second thing, because I think the idea intrinsically to a person in the population, the first thing might be a bit hard to understand, but the idea of taking a known drug, and then saying, oh wow, it works in something completely different, like repurposing a drug, that's kind of an attractive idea, because the drugs obviously that we know about them. So can you tell us a bit about your work you did there?
That's it. I mean, that's exactly, well, the reason, I think a couple point about this is, as you know, the SCOOH is very rare, right? And if you think about typical drug development, it takes about 10 to 15 years. If you identify a potential drug target in a laboratory, develop the drugs, pass all kind of tests, going through the clinical trial will take 10 to 15 years and lots of money,
right,
resources. And certainly for SCOOH, because limit size of patient sample, that's very challenging to do. So the idea of taking the drugs that's been approved, have been shown to be safe to treat patients, I think that would really cut down the time and resources we need to find a potential effective treatment for school patients.
So when you did that, what drugs did you come up with?
So it's a complicated sort of study, but we actually start going back to the genetics.
Yes.
We actually designed a study using the library against those protein family called kinases.
Right.
And
when you mean a library, you don't
Sorry.
you don't mean a real library.
That's right.
You
It's
mean
not
a
a book
collection.
like
A collection.
that's
of,
right. A genetic tool
Exactly true.
to inactivate different kinases one by one.
And kinases are what? They're proteins that kind of activate things.
That's right. So kinases are those enzymes in cells who activate pathways.
And you need kinases.
That's right. Especially in cancer cells, many kinases seem to be hyperactive.
Right.
Or important for.
I guess
control of
kinase
survival.
means like mean going somewhere, like kinetic. So it's like an A's that makes things go somewhere,
Okay.
right? So they're like
I didn't realize about
they're like
kinase.
they're like drivers.
Yeah,
They're like a driver, right?
it is. So
So you want to knock out the driver. Yeah.
exactly. So try to identify which kinase is the essential driver, or vulnerability, if you will, in the cancer cell.
Yeah.
So from that study, we identify the drugs against CDK4/6, the cell cycle kinase, important for cell cycle progression, the cell proliferation. Cancer seem to be.
Would they have to? We all need. Every cell needs to divide.
Yeah, especially cancer cell. They're
cancer
very
cell.
highly dependent on the proliferation.
Right. So you were able to find a drug that targets that process, which seems to work particularly well in tumors that don't have SMARCA4.
That's right. So that's how we found.
And only those tumors. It doesn't work in other tumors in the same way, right? It doesn't work in the same way.
Well, so the drug's actually originally designed to target breast cancer patients,
Right.
where they show a hyperactivation of those kinases.
Right.
So it's really addictive to this enhanced activity.
Right.
So if you take it away, cancer cell die.
Right.
In the context of school, we found the opposite.
Yes.
Well, I would not say opposite. It's actually the other way around, that we found that in school cells, there are limited activity of those kinases.
So it's hardly anything present, and you could knock that down more easily.
Well, they have enough to go on to proliferate,
But
support a cancer cell, but they are much less buffered.
So where are we going with that now then? I mean, that was some years ago now. What's
so
the next step, do you think?
Our study, obviously, is joint study with you and other colleagues that has led to an ongoing clinical study. It's a new arm looking at treating patients, including school, but also lung cancer patients with SMARCA4 mutation,
right?
To treat with this CDK4/6.
So we'll come back to the issue of one of the problems, the challenges and the opportunities that trying to treat small cell cancer ovary presents. So we'll come on to that later. But I think probably people listening in want to hear about like your most exciting new finding, right? Because that's always what you want to present the most. So what's the hottest thing that has come out of your lab in the last year or two?
Well, the most recent paper we recently published was actually identification a vulnerability of those school cancer cells to a nutrient dependency.
Nutrient, wow.
Yeah.
So it's just like a vitamin or something.
Yeah, so this is in collaboration with Dr. Yeming Wan at UBC, and yourself and Dave Huntsman and so on. It's a team effort, really.
It's a Canadian kind of
exactly.
collaboration,
Yeah. So what we found is actually school cells, because they lost SMARCA4 gene.
Yeah.
In contrast to normal cell, they can take a different nutrient to sustain their survival.
Because we all need food to survive.
Yeah.
Right.
Different type of nutrient, different pathways.
So it's almost as though it's almost as though if a human could only survive on one food and you stop them eating it,
and you will die, right?
Right.
But in reality, normal cell you can take it, different type of nutrients.
Right.
But in school, it turns out they're very highly dependent on type of nutrient, particularly one amino acid is called glutamine.
Right.
And this is taken by receptor, taking this glutamine.
Right.
So if we shut down this intake glutamine tumor
prevent
cells,
glutamine from getting in.
That's it. And
that's hard though, isn't it? Isn't that a hard thing to do?
Well,
to block. I mean, because we all need glutamine. So how can you do that then?
Yeah, so currently there's no drug available to block a particular transporter.
Yeah.
But what we figured out, actually my student figured out.
Students, smart students.
Always learn from the students.
Yeah.
What he figured out is this particular transporter not only transport glutamine, it also transport the other amino acids called alanine. So he came up with this idea that now if you can feed the tumor cells a higher alanine, it will in principle compete the intake.
So then the glutamine can't get in because alanine's taken over.
That's right. And the difference is Now, in tumor cells, if you block this, it will crap out, they will die.
Yeah.
But in normal cells, if you block the glutamine, they can utilize other resources to sustain the survival. Thereby, you don't really see the same.
And alanine, I mean, I was reading, alanine is like people use it in bodybuilding, people use it to treat diabetes, so it's obviously safe, right? You can buy it over the counter.
That's it. So it's been shown established as quite safe, at least in a certain dose that have been studied.
Yeah, obviously don't chug it. But
so the difference between, just to be careful to talk about amino acids. So the alanine and glutamine are two highly abundant amino acids in the bloodstream.
Right.
All the other amino acids, if you take too much, it can be toxic effect.
Yes.
But not alanine.
Because there's so much of it anyway.
Yeah, so your body evolved in a way to tolerate high alanine.
Yeah, so that seems to provide some great opportunities, but maybe we can segue into some of the challenges, because clearly, alanine is widely available, you could just take the stuff, but how would you evaluate whether it works or not?
Yeah,
because what are the challenges you see as we go forward with this research to try to find the best treatments? The best treatments.
Yeah, in fact, coming to the alanine situation, right? The study we have done so far in cancer cell lines, in cancer mouse models, in where we actually implant the human tumors, SCCOHT patient tumors, into the mice and let it grow to certain size.
You get a human tumor,
grow
and you grow it on a mouse. And how does that work?
So obviously these
How do they grow it? Because it's not the same tissue. So how does it?
That's right. So these are specialized mice strain. Doesn't have an immune system.
So the mice don't reject.
That's it.
I see.
Because it's important to study in a live animal contact, because you want to make sure the drug delivery can reach the tumor mass.
As though you're treating a patient.
Exactly.
So it's like a mouse trial.
That's it. So far the data we collected is based on the mouse trial.
Right.
And of course, how to extrapolate this information to the human is the next challenge, right? Because we can estimate how much alanine we can take, based on a study in the mice, but it still needs to be verified.
So what resources do you think you need to make this really work? And what would if you had a wish list? What would it? Apart from a load of money.
There are two, right? Now I think the two essential sort of resources I can imagine. One is to re-establish increased number cohort of PDXs. So these are called patient-derived xenograft, as we discussed.
And xeno means foreign.
That's right.
So I think a Greek for foreign. So it means it's a mouse. It's a human tumor growing on a mouse. So this is a resource we've been trying to build. That's part of the registry that we've been doing.
That's it.
It's very difficult because, as many of you watching this will know, the diagnosis of small cell cancer is unexpected. It's not like you have the disease before you're diagnosed. Like if you have a breast lump, you feel a breast lump, and then the doctor says, well, I think you may have breast cancer, and you do a biopsy. And then it proves it's the case. With small cell cancer, it's, you've got a mass in the abdomen in a 25-year-old, well, that's probably a cyst, and it turns out to be this diagnosis. So no one's prepared for it. So we don't have the resources to get the samples to us straight away, unfortunately. But sometimes the disease comes back. Again, very unfortunately, and when that happens, that's the time when getting the PDXs to Sid and to people like Sid in Montreal would be super helpful, because we can share them then with other people. The mandate is to share them with researchers around the world, but unless we can do these mouse trials, because the issue really is that, as David Huntsman said to me once, there are more drugs than there are patients. And there are more potential therapies. There's other people. We'll come on to other people's work in a minute, but there are lots of therapies, but how do you get that into a trial setting? For breast cancer, there's 100,000 cases a year in the US. Small cell cancer of the ovary is probably 10,000 times rarer. So you're never going to have a trial like that. So we're thinking that maybe some kind of mouse trial.
That's it. So we need to establish which drug, which treatment are the best that we can try first.
Right. And
in order to establish that, we need to test many different models, right? Because so far we have access to probably a handful of models.
Yes.
And even though, as you mentioned earlier, the SCCOHT is caused by single gene inactivation.
Yeah.
But the difference between different patients that can dictate the response to the drugs. So we want to be sure what we're finding here is applied to different tumor models. So that's why it's very, very important to sort of increase our cohort of PDX models to be confident that what we found will work in majority of the cases.
Okay, so let's do just imagine that you've got your 10 PDXs now in the lab. What would be the, obviously you want to test palbociclib, you want to test alanine and maybe combinations and chemo. What other, other researchers have been working in this field, obviously. What other drugs or agents would you kind of add to that list?
Yeah, so, again, this is really collected effort by many different groups around the world, Canadian, US, and so on. Early days we have, before we identified the CDK4/6 inhibitor, couple of drugs against some of the epigenetic modifier, EZS2, HDAX has been shown to have activity against the animal models of SCOT, and as well as some of the multi-kinase inhibitor, and more recently the
arginine synthase.
That's it. And as well a checkpoint inhibitor.
I was going to say, checkpoint, you checkpoint inhibitors, those drugs are so famous now, the Nobel Prize was won some years ago for their discovery. They've been used in many different cancers. In a sense, it's a bit surprising because you think of them working in people, in tumours where there are many, many mutations. And of course, the one thing about small cell cancer of the ovary that's perhaps, not a unique feature, but is very unusual. Not only is it caused by a single mutation, but it doesn't have many other mutations. So, that's an unexpected feature because usually the checkpoint inhibitors work because there are lots of mutations that create new proteins that you can make, as it were, your body kind of respond to as foreign proteins. So that's an interesting point, and maybe it doesn't work. Do you think it works through the same mechanism, or?
Well, I think this is really active research area. Even though SCOT has little genetic alterations, but turns out SMARCA4 is a master regular gene expression and additional processes. So loss of SMARCA4 might create different combination of new proteins that need yet to be discovered.
You could spend a lifetime on this. You could spend a lifetime on SMARCA4, particularly because we know that different types of mutations in SMARCA4. So the usual mutation that causes small cell cancer of the ovary is what we call a truncating mutation that stops the protein, cuts it in half, if you like, and usually the protein disappears altogether, or only half of it is present, which isn't good. So the business end of the protein might be missing, but sometimes you have a missense. That's a tiny, subtle amino acid change, very subtle. The protein looks completely normal, one letter is changed for another, and that causes a completely different condition, a type of neurodevelopmental disorder called Coffin-Siris syndrome, which doesn't look at all like a cancer. So it's kind of obviously got some very important properties that go way beyond cancer. So we have to kind of be careful. We can't just knock the thing out, right?
Absolutely.
Okay. I think that's really, where we wanted to get you to today was some of the most recent work that's come out of the lab of Dr. Huang here at McGill in the Department of Biochemistry. And we thought maybe this might be a good time to see if you have any questions for us, which Melissa will handle. And otherwise we can carry on a little bit more, but maybe this is a good moment for you to see if there's any questions.
Okay guys, so if you have any questions, just feel free to put them in the comments. I'm happy to read them out loud for you. We are not judging any questions at all for either of the doctors that are speaking today. If not, I'm sure they can go on and on about their research, and they're happy to. But if you guys have any specific questions, maybe about the alanine and how you want to incorporate it in your treatment, and if you had any questions about that, happy to help.
So maybe while we're waiting, you'll let me know, So Sid, how does funding work? I mean, obviously getting money to make this happen is critical. I mean, this isn't a $5 job. We're talking about millions of dollars, right? So how do you, what's the process?
Well, the process, typically speaking, for us is really just to write a grant research proposal based on the previous cumulative data, to come up research plan and ask the government to support our research.
So a grant, that would be like sort of several pages long, would it be? Or
usually like 8 to 10 pages, depends on the funding agency. And as you know, the funding climate is challenging, so it's always very competitive.
And what percentage of grants do you think, if you submit a grant, if say 100 people submit grants, how many do you think would normally get funded? I mean,
The average in Canada is about 15.
Wow.
1
So
5.
only 15
That's
out of
it,
100. So
yeah.
if you're not part of those 15, then you got to try again, I guess.
That's it. Yeah. So keep trying.
So the next round, the next round will be what, 6 months later or something, or a year later, or.
Well, yeah, 6 months.
Yeah.
Yeah.
And what about outside Canada? Can you apply to US and other agencies?
Yeah, you could. So, we have collaborations as
Yeah.
a potential joint force between the US lab and Canadian lab have a application. So
We're good. So we have some questions coming in. I'm just
Okay.
going to read them out loud. Sorry,
Great.
guys, you were
Sure.
going for it.
Yeah.
So we have, I'm not going to say anyone's name out loud in case you guys wanted to remain anonymous. So we have someone who was wondering when it was too soon to incorporate alanine into patients' current treatment regime. So I'm not
Is it too soon, you're saying?
Yeah, so when would be too soon to incorporate it?
When would be too... Well, this is a different... I find this a hard question to answer because, the paper was published in a scientific journal, went through peer review, and has been, deemed to be of interest to be published in a prestigious journal, which is good. But the next step of getting clinicians to actually give the drug, normally there has to be some kind of trial in a human. I mean, what you call a phase 1 trial, which is to do with finding the dose that works best, right? But in this situation, it's again, for the reasons we were explaining earlier, the disease is so rare, you'd have to wait an awful long time to get enough patients. Say you had 5 women who had small, you'd have to gather that data, across many different sites across America, and show the drug was safe. I mean, that would be the first thing, what dose, but you wouldn't be looking for an effect, you'd be just saying, is it toxic at a certain dose? But with alanine, we kind of know that already. We know that it's safe at quite high doses. So the phase 1 part of it doesn't seem to have a strong rationale. And then phase 2 is to actually look at outcomes, like what actually happens to people. And the problem there is the standard treatment, as many of you will know, is high dose chemotherapy, so 6 heavy dose drugs followed by a stem cell transplant. So, alanine may add value, at that point, but obviously most of the heavy lifting is done by these very toxic but effective, in some cases, chemotherapies. So I would say, I can't see that there's a downside to adding it early on, personally, but I'm not, I should say, I'm not an oncologist, I'm a medical geneticist. I'm not recommending that people go out and take this stuff. But on the other hand, it's hard to see how it will really truly be tested at the moment. I mean, what's your sense?
Yeah, that's a difficult part as well, right? We have not, obviously, nobody has systematically tested alanine plus chemo.
Yes.
Right? We do know a couple examples of patients actually do take high dose alanine in the presence of chemo and they seem to be doing well.
So so these people basically contacted us and asked us, and we said, look, again, we're not. Sid isn't a medical doctor. I am, but I'm not an oncologist. We're not recommending stuff, but we do know that it's used widely by people with diabetes and people who sometimes bodybuilders. And it doesn't appear to be any long-term side effects of taking quite high doses. So it was hard for us to see the downside. Yeah, and it's such a devastating disease that even a small advantage, particularly when taken with chemo, we thought was probably worthwhile. So I wouldn't, again, I don't want to endorse something that is not appropriate for me as a doctor.
I would suggest they speak to the oncologist.
And show them the paper.
Yeah.
They can find it on.
I'm happy to answer any questions.
Send you the paper and see what they say. But my sense is it's likely to be very non-toxic.
And in these 2 cases, we know the oncologist has no objection of taking alanine. So.
No, and the patients have taken it. And
again, I think it's important to tell the doctor. And if you have pre-existing metabolic disease, I would be worried about this. But if you don't, I think it's...
Which would be a bit unusual, right?
Yeah.
So for the person asking how to bring it up to their oncologist, I'm happy to send you Sid's paper. You can print it out and just show it to your oncologist, or you can just show them this live and let them know that this was up for discussion and you were considering adding it to your care.
So the paper is actually accessible to everyone online. It's open access, so you can just share the link.
You don't need to send the paper, just send it. If you click on the link, which Melissa will send you, it's called a DOI. You click on the link, the paper will just come up with, because we paid. You have to pay $10,000 for the privilege of letting people be able to download it. But that's the way it goes these days.
And can you clarify if it's L-alanine or beta-alanine?
It's L-alanine we tested. Beta-alanine we also tested similar effect, but less potent is L-alanine.
Yeah, and that's levo and beta, whatever it's called. It's L and R.
Yeah.
L and R. Yeah.
Great. So the next question, do you feel the patients that had a recent pregnancy or miscarriage can cause this type of cancer? Myself and a few others were pregnant shortly before being diagnosed.
No, I think the reason it is because the mean age of diagnosis is the kind of age in which people get pregnant. So if a disease happens in an age range when these things happen, it often would be apparent that there'd be a connection between the event and the cancer. For example, if you said, my father's 80 and he's got dementia, you would say, well, it's because he's 80, or because he's 90. If you were 20 and had dementia, you'd say that's totally abnormal. So I think it's just the fact that that's the age range at which small cell cancer occurs. There's no evidence. There are some tumors, right, that are related to pregnancy, like choriocarcinoma, tumors like that, or sort of molar pregnancies that are related to being pregnant, okay? But this isn't one of them. So I think it's just the fact that it tends to happen around the age at which many women are getting pregnant.
Great, thank you. So we have another question. His wife just completed his 6th cycle of Pembro plus 4 cycles of Zepzelca after failed BMT radiation. They started taking the alanine powder. I'm not sure if that's a specification instead of the pills. And they took it for 2 months with no success. Should she continue taking the alanine? So is there an amount of period of time that it
no success? You mean it didn't make any difference to the tumor size?
No difference to tumor size so far.
Well, hold on. You have to be careful what you mean. But I mean, if the tumor is expected to get bigger, and it's not getting bigger, then that's not necessarily a failure. I mean, a failure would be the tumor's getting bigger. If you take a drug and the tumor gets bigger on the drug, it's not working. But if the natural history of a tumor is to get bigger, which it is in most cases, then if the tumor stays the same size, well, that's not a victory, it's not a defeat either. So I think you have to be careful what you mean by that, and we'd be happy to have these discussions offline with specific people if they have questions. Again, I'm not an oncologist. I'm a medical geneticist who've helped with one of the people who found the gene being connected to this disease. But I do know we have a lot of contacts. Stuart Pressey in Cincinnati, Amit Oza in Toronto, other colleagues around the world in France in particular. Isabelle Ray-Cocal.
He said the tumor quadrupled in 40 days.
Well, that's obviously a sign it's not working.
Yeah. I mean, we did see mixed response in different models we tested, right?
Yeah.
We have one model respond very well, a single agent.
Yeah.
The other is partially suppresses growth compared to untreated controls.
So as I understand it, the Pembro isn't working either then?
Yeah.
Is that the message?
Yeah.
Well, that's very unfortunate.
Do you have any opinion on Zepzelca?
I don't actually know what Zepzelca is, I'm sorry. You'd have to tell me.
He can't find any studies with SCCOHT.
Yeah, I don't know what that drug is, I'm afraid. I'm not, as I said, I'm not an oncologist. We can look it up, but I don't know. If you send us the details, send them to Melissa, we can sit down and I can look it up. But I doubt if it's well known because we haven't.
Is that a CDK4/6 inhibitor? Just different brand name?
It's under the
yeah.
No, we'd have to add with, you'd have to do Ciclip, right?
But that's a sort of common name if you a trade name. Maybe.
Oh, I see. It could be a trade name.
Could be a trade name.
Yeah. I don't know.
I know we never use a trade name. We
always
look
use
at biology.
The real drug names, not the trade names. But anyway, we can look it up, or maybe Melissa can.
But I'd say that's really a challenge of drug resistance, right? It's, many.
Is it possible lubrinectin? Is that something you guys know?
No, I don't know.
No, sorry, I don't know.
I think it's best if you just send me a picture of maybe the medication, and then we can look at it on our end for you and let us know if there's anything.
We'll definitely try and help you there, but I'm obviously very sorry that this is happening. As I say, Joe Pressey, Amit Oza are the real people I know. People at MD Anderson are very good. Dr. Schneider, I think her name is. No, not Schneider, I can't remember her last name, sorry. I know she's from Quebec, I can't remember her name. But there's many, there are big centres that treat a lot of people. Joe Pressey's certainly treated a lot, but please reach out to those people in terms of novel therapies. Yeah.
Okay. The next one we have, my friend Chris is unable to attend. Her daughter, who has passed away, was a big milk drinker and is wondering if there's any correlation.
A big
milk like milk drinker. No,
I honestly, again, you know, it's we're all looking for reasons why things happen. You know, we're all looking for explanations, and that's what we're doing. Essentially, we're doing it by hypothesis testing. So the hypothesis would be, this drug makes the tumor go away, and we test it, and it doesn't, or it doesn't. If it doesn't, we move on. Something like that, you can't really test it. I mean, you can't say, let's give, 500 women, too much milk and see what happens. So you can't really answer it in the same kind of way. But in terms of explanation, you also think about how plausible is that as a reason for the cancer to happen. And it's very hard to see what the connection between too much calcium, too much phosphate. I mean, what could really be the cause? It's very hard to think that really is the reason. It's more likely that it just happened to be a characteristic of this young woman, and unfortunately she got a small cell cancer of the ovary, but they're not really connected. They're just two things that happen to the person.
Okay. Would you recommend taking alanine preventively for NED patients after finishing treatments?
Yeah, that's a very good question. I mean, we certainly not able to model that, because one of the limitations about this, we don't have a sort of mouse model to mimic how the tumor developed.
One of the things, in fact, that you're working on, you said, is to develop a mouse model that would instead of being so having a human tumor grow in a mouse is great, but the real best model would be a mouse that got small cell cancer of the ovary, because then you'd have the perfect.
That's it. So we can study that. We can study how we can prevent.
And it turns out to be very hard to do this. Many people have tried, but Sid has got a great idea of knocking out SMARCA4 on the one hand, but you also have to knock out SMARCA2, which is his partner, and so you have to do that in a special kind of way. So if that comes off, we may be able to use to answer questions like, should you take alanine? You could treat the mouse with alanine. Now, is it dangerous? Probably not. Will it work? I mean, how are you going to know, in fact? Because if you took alanine for 5 years and the disease didn't come back, and then it came back after 6 years, how do you know it wouldn't have come back after 1 year? It's not, obviously not a complete success, but it may not be a complete failure. I mean, would I do it? I mean, I probably would, because I don't think it's dangerous. I'm not a big fan of people spending a lot of money on things where we have no idea if they work or not, and they could be dangerous. And people do that a lot of the time with alternative therapies and things like that. But here, this is something that's known, and it's in the doses that are reported, it's not dangerous. So I'd be hard pushed to say I wouldn't do it. But on the other hand, as I said, I don't want to say, look, I know it's going to work or whatever. As I said, I'm not an oncologist, and I don't think I would want to make too many statements of that nature. But
if we have the model, we can test it. That's the challenge.
Yeah, that's the challenge. Yeah.
We started using the supplement on our daughter immediately post-treatment. How long would you recommend using it for?
Yeah, that's a very difficult question to answer as well. Again, we don't have so the PDX model we have usually is the course of maximum 2 months at a time until we have to stop the experiment. So we can again highlight the importance to develop probably a proper model to study that.
I don't know. I mean, again, if she's not suffering consequences of this, I'm not sure I've got a strong reason to stop it. I mean, we just don't know is the truth. I mean, the trouble is you can see from our answers, it's a lot of I don't know, it could be true, the facts are pretty thin on the ground here, but the alanine story is at least a hope, because it's not dangerous. The trouble with some of these therapies is that, almost all drugs have side effects, and some of them are really quite devastating. And can be checkpoint inhibitors, for example, are great drugs, but I had a patient recently who had an inflamed heart, had to stop the drug. So they're not completely benign, whereas alanine does seem to be pretty on the benign end of things. So I'm not sure there'd be a strong impetus from my point of view to stop it, you know, unless it was making her sick. Obviously, if she didn't like it or it was interfering with other activities in her life, then I would stop it. But it's, you know, and obviously hearing about the case earlier, somewhat dispiriting of somebody, you know, where the tumour's growing on alanine, but you know, it's not going to work in everybody. You know, there's no drug that works in every person. But if it, to be honest, I mean, from my perspective, if this drug works in one person, it was worth it, you know, because, you know, what's one person? One person is one person, you know, this is like critical. So I would, again, encourage you to just discuss it with your doctors locally, but I don't think they're going to know more about it than we do. They're just going to help you make decisions and monitor vital signs and so on. And then in the end, to be honest, it is a bit of a personal decision, because I don't think we know enough to tell you intelligently, yes, you should stop it after 6 months, you know. I mean, I don't know.
Perfect. There are no stupid questions. I just want to repeat that because I see a few of you saying that. There are absolutely no stupid questions. We're really happy to take everything.
Yeah. There's stupid answers. But there are stupid questions, yeah.
Should those with the SMARCA4 mutation take preventative measures? What do you do if your doctor is unfamiliar with the mutation and is against any preventative measures?
That's a great question. The problem with SMARCA4 is that obviously it's relatively rare, so many people will not have heard of it. Most family doctors will never have heard of this gene. Most oncologists will never seen a case. Only in specialized centers would they have treated people with this disease. So I think it's important to try to find a specialist who at least, when you say SMARCA4 or when you say small cell cancer of the ovary, they don't look at you blankly. It's important to find, I think that isn't, you know, and you may have to travel to find somebody of that nature, but most major centers in most American states and most Canadian provinces would have at least one center that have treated these people before, is my guess. I mean, maybe not in some of the smaller states, but certainly, you know, the big states, big population centers, California, Texas, Massachusetts, and so on, will have definitely have had people who've treated this condition. In terms of the second part of the question, Melissa, was about prevention.
So what to do if your doctor is unfamiliar with the mutation and is very against preventative measures?
Well, it depends what you mean. The only prevention we know of is to remove the ovaries, unfortunately. We don't have a drug that will, you know, like we said about alanine, we have no idea. We would not recommend you say alanine or removal of the ovaries because we have no idea it's going to work. Remove the ovaries will work, but obviously is pretty devastating. And we have been involved in quite a number of cases. Melissa and myself and other people in the group have been involved with quite a few cases where people have contacted us from, you know, parts of the US, Canada, asking our opinion about what to do. And of course, it's a very, very difficult subject. You have someone who's age 10 who has a mutation in SMARCA4, which is known to be pathogenic and could cause a disease, or whose mother maybe died of or had this cancer. Obviously, the question of removing the ovaries at age 10 is difficult for all sorts of reasons. Ideally, you'd like to wait for puberty to happen. And it depends who you speak to. We've seen cases, there was a case report written up recently of a 6-year-old where they did the surgery, which I was a bit against, I have to say, but I wasn't really involved in the case. But you are taking a risk because, you know, the disease could happen before aged 18. I mean, it has happened. We know it happens. So there's a risk, but on the other hand, removing the ovaries has its own, you know, very, very serious side effects. If you leave the uterus in place, obviously the child or the young woman could have a baby later on through surrogacy and so on, or through carrying through IVF. But removing the ovaries obviously has a pretty major effect on development, and you'd rather wait until they've at least hit puberty, in my view. So if the doctor is really unwilling to discuss this, I think you have to find somebody who is willing to discuss this. I mean, to be honest, you know, this is what happens. You meet doctors who have particular views, and you sometimes have to find ways to find other opinions. And we're very happy as I say, in a non-jurisdictional way to tell you our advice, and we've given our advice, but I'm not saying that you have to follow anything we say, but we have tried to advise people, and we can direct you towards centres where they do know about this condition and would at least consider a request for preventive interventions. But just in terms of prevention, all we know of is surgery right now. We don't have anything better, unfortunately.
I want to bring this one up because I think it's really good to bring awareness to it. So the question was, what global efforts and awareness can the community do to share the need for genetic testing for SMARCA4? So I believe it is now incorporated into most genetic testing to look for SMARCA4?
Yeah, that's a good question, Melissa. It depends what you mean. I mean, certain companies include it. I mean, there's an upside and a downside to that. I mean, things are so incredibly uncommon that including it on a generalized test for cancer might be a bit overkill, because you might actually do more harm than good, because you might find a load of variants that don't actually cause cancer, and then people don't know anything about it. They could get overly worried. It may cause more harm than good. But I think it's important to be aware of the condition and to be aware of the need for genetic testing if the cancer arises, and to test relatives. If there's a known variant in your family, then obviously testing other people in the family to try to, prevent this. For like a 40-year-old woman who has a SMARCA4 mutation that's known to be disease-causing, we would recommend oophorectomy, removal of the ovaries. We would not question that, right, at age 40. So I think that's the thing to get out there, is that if you have this disease, you need to see an expert. You need to have the test done on the tumour and on the blood, and we can facilitate that through the registry. If you go to the website, it's www.SCCOHT-SMARCA4. If you just put registry, small cell cancer, whatever, and Maren Peterson and people like that have been extremely helpful in promoting this. The EVA Peel in the UK have supported what we've done. So we've had a lot of help from people to get the word out there. And I think the best way, and as I said earlier, the best way to help the community, I think, is to try to get these tools in the hands of people like Sid, who are the real hardcore researchers doing this work, trying to find cures. We need these patient-derived xenografts. We need the tissues, the tumors, the blood samples. There's the whole other area of trying to make sure that anybody who finds a variant, that we can interpret it properly for you, and that's work done by Leo Witkowski in our group, is to make sure that if you get a report from your doctor that says you have a mutation in SMARCA4, that it really is a serious one, and that's something that we're working on quite actively at the moment. So there's the two sides to it. But yeah, I think getting the word out is important, and trying to build the resources is also a critical part of it.
Great. I think this one works perfectly with what you were talking about. So my daughter did not test positive for the genetic marker, but the tumor did.
Right.
In this example, would this be picked up in a genetic screening, assuming a somatic occurrence? Maybe you want to explain the difference between?
So the difference is, so the gene is responsible for nearly all the cases, okay, as we said earlier. But there's two ways this can happen. And I think it's explained a bit on the website. You can either you inherit one mutation, or you occurs what we say de novo, just in you. So you have this one, you have two versions of the chromosome, they're called alleles. One from your mum, one from your dad. So if one copy gets the mutation, so it doesn't work, and the other copy works, then you're at risk for small cell cancer, but it doesn't happen, okay? And then what happens, in the ovary, the other copy goes missing, and now you have no SMARCA4, and the disease happens, right? So that's if you inherit one. The other situation could be, actually, your parents, both of their copies of the gene were completely normal, but in the ovary, one copy went wrong. Just the ovary, nowhere else.
In the ovary of the patient?
Yeah, the ovary of the patient, not the mother, the ovary of the patient. When they were growing up in utero, we don't know when it happened, probably quite early on in life. It's an accident. It's like being hit by lightning, right? And then the other copy, unfortunately, again, probably because of chance, hit by lightning, goes wrong as well. Now you have, so the difference between the two is, in the first case, you can pass it on because it's in every cell of your body, including the ovaries or the testes, and you can pass it on to the next generation. In the second case, you can't pass it on because it's only in the ovary and it isn't really, it occurs, it won't occur in the egg cells, so you can't really be passed on, at least that's what we think. So if your daughter had 2 genetic variants, okay, in the tumor, then we know it can't be in the blood. You just have to be careful because it's possible the tumor could have 1 mutation, right? Then you don't find the other mutation, you don't know where it is. Is it in the blood, all the body, or just in the tumor? And if you don't find it, then you can't be certain it's not inherited. But usually, if you find 1 mutation and you find nothing in the blood, it means it's the other people in the family aren't at risk for the disease. But again, you can ask us if you want to contact myself. You know, we could look into specific cases. But I do encourage anybody who's had is the parent of a person who's had this tumor, or who has had this tumor themselves, to sign up for the registry and allow us to get hold of the tumor samples and make sure that we do know that there are, you know, what was the cause of this cancer, so at least we can try and prevent the next generation and help Sid with his work and learn more about what the risks for this condition are. You know, what is your risk of small cell cancer if you have a mutation in SMARCA4? What's your risk by age 24, which would, or 25 or 30 or 40, which would influence decisions about obviously removing the ovaries. If the risk was only 2%, you wouldn't do the surgery. If the risk is 20%, you probably would. So we don't really know what those numbers are, unfortunately.
So the first case you were talking about, which is inherited, we can detect with a blood test?
Yes.
Yes. And then the second case is only found, the second type that you were explaining, it's by chance, it's really an occurrence that's random. That would only be found in the tumor.
Correct. And we'd have to sequence the tumor to find it. So we need the actual physical tumor to be sent to us from the hospital.
Great.
And then we can sequence it.
Perfect. Their granddaughter just completed treatment. Is there any indication that the COVID vaccine could have accelerated her tumor occurrence, considering this cancer typically hits women in their 20s? The girl is 15 years old.
Yeah. This is a bit like the milk question. And it's also, I've had several people ask me in the clinic, do you think the cancer is caused by COVID or accelerated by COVID? Again, it's a bit, you know, we're looking for causes, right? We're looking for meaning in a world that doesn't always have meaning. We're looking for reasons when we don't always have answers. So we're looking around to see, well, what happened in a time relatively adjacent to the cancer diagnosis that could have caused it? Pregnancy, milk drinking, COVID vaccine. But again, I don't want to sound like I'm dismissive of these ideas, because you shouldn't really dismiss ideas without data. But, you know, COVID vaccine was given to millions of people, right? And, you know, small cell cancer is terribly rare. So I think if it was a clear association, I think we would have seen a big spike in the number of cases. Like there were some things that were caused by, you know, you probably heard about the particular AstraZeneca vaccine was associated with some kind of funny clotting disorder in women of a certain age, and that was real. I think that, and they stopped. You know, the vaccine was still given around the world in certain circumstances because overall it still was beneficial. You know, a very cheap vaccine, and it's probably worth it, right? But overall, in Canada, we said we're not using AstraZeneca because of these events. So that was accepted. It was a very, very rare event, like small cell cancer of the ovary. But there are enough cases that people said, it's probably connected in some way. So if small cell cancer of the ovary really was caused or made worse or exacerbated by the COVID vaccine, I'm almost certain somebody would have spotted that, because there's been so much monitoring of any kind of complication of these vaccines, and so many attempts to find this kind of thing to make sure they are safe. And when you're giving something to millions of people, it better be safe. And in general, the Pfizer and the Moderna vaccines and others like it have been extremely safe, you know, incredibly safe, and probably saved tens of thousands of lives. You know, and as you probably know, the Nobel Prize was won by the 2 researchers in Pennsylvania who discovered how to make this thing happen, right? And made the success for the testing companies that ended up, you know, making the vaccine. So I think that it's been recognized that this stuff really works. So I don't think you can honestly say that that's why the 15-year-old got the disease. I think she got it for very unfortunate reasons. But I would stress that in our hands, everybody under 15 had a germline mutation, had a mutation that was inherited from a parent or was acquired when they were in utero inside their mother. So I would encourage anybody who's has a person affected by this disease to get tested for the germline with a blood test, which we can arrange. If you can't get it done locally, we can do it for free. And if the person is deceased, we can test the tumor. And if there's normal tissue from the operation, we could test that as well. So there's lots of ways to try and find this out. But I personally would not think that the COVID vaccine has got much of a role here.
Perfect. Sid, this one's for you. So we're talking about the alanine, do you have any suggested dose or frequency of incorporated that has success with ongoing treatment, or just if they're taking it preventatively? What would you suggest?
Yeah, so that's it. So all of the experiments we did, obviously in animal models, and based on estimation, there's a formula you can calculate. There was estimated to be about 16 grams per day for a 50 kilo person. In terms of length, again, we had the same question before. It's very hard for us to know how long you will have to take as a person to see the effect. I mean, again, all experiment done in the mouse, the xenograft models, that's up to 2 months the time.
That's 2 months of a mouse time.
Yeah, mouse time. So it's very hard for us to know.
Yeah.
That's it. So that's the next big challenge, really, to be able to validate this and to figure out what's the best way forward for the human.
Yeah, we're going to try and meet with some of the oncologists that we mentioned earlier to try to sort of see if a way that they can integrate it into their treatment plans. But it's difficult because the heavy lifting is done by the 6 drugs or the 5 drugs or whatever, VCP, BAE plus stem cell transplant is often used as a standard of care. So we wouldn't in any way replace that, but if you add it in, how would you know whether it really would unless you did a trial where you gave it to some people and not to others? And it's kind of hard. It's so rare. It's about to be optimistic to think that we're going to get the answer through traditional trial means.
Is there any less of a chance of reoccurrence if the patient does not have the SMARCA4 gene in their blood but did have it in their tumor?
No, that's a great question. For recurrence, I think no, but it depends whether the other ovary is still left behind. So if somebody had a tumor at their right ovary and the left ovary was left behind, and the cause was an inherited mutation that was present in all of the cells, then the other ovary has the mutation in it as well. And so you could get another cancer in another small cell cancer, a new one, not the one you had before, in the other ovary. So, we've seen at least 3 cases of proven of this. They're not published actually, but we have one of our own, which Sid and I have worked on, and there's a case in Oregon I know about that probably is the second one. And then the original publication from many years ago, if you read the paper, one of the original papers from Scully, who was like the doyen of gynae pathologists, there's a case there that looks very much like it's a second cancer, a new cancer. So if both the ovaries are removed, I think it doesn't make any difference whether you inherited the variant or if you acquired it. But if one ovary is left behind and you're now 5 to 10 years out from an initial diagnosis, it's certainly something to consider, because we have seen a case very tragically where the one ovary was removed, the patient was cured, and they got the cancer in the other ovary, and it's a new cancer. And so obviously talk about being unlucky, that's unlucky 3 times. You inherited the mutation, you got cancer, then you got cancer again. So that's pretty unlucky.
Great. Is there any way to determine if somebody has a somatic mutation before the cancer occurs? So I know if there's a hereditary one, we can do a blood test. Is there any way to detect?
Well, I suppose that's ctDNA, isn't it? Perhaps. I mean, you could imagine.
We also don't want to condone everyone in the world going to get testing if we don't know, right?
It's so difficult because it's so rare. So you'd be basically doing some kind of attempt to look for SMARCA4 mutations in the blood being shed from an ovarian tumor, which could happen. I mean, it's a good question in a way. Can the tumour shed cells into the blood circulation before it's very large? Possibly. We know this can work for other cancers. So you'd have to imagine a situation where the tumour is shedding a SMARCA4 mutation into the bloodstream, which is picked up by a test, and that means you find it before the tumour is very large and the patient's cured. Great. But to do that, you'd have to be testing every woman, because you'd have no idea which woman would get this tumour. It's so rare. Unfortunately, it can hit any woman randomly. I mean, it is like being hit by lightning. It's like it's not even a good analogy, because even that has causes, right? I mean, I don't know. You hear these stories of people walking down the street and a bit of building falls on their head. You know, it happened in Montreal some years ago. You know, you're walking along. There's 100 people walking along, and the brick falls on your head. You know, I mean, you can't know that's going to happen. There's no way of predicting it. So it's that kind of thing. And so it would be like saying everybody has to wear a crash helmet walking down the street because one person is going to get a brick fall on their head. Well, nobody would do that. Nobody would do that. So it's too difficult, I think, is the answer. But it's not that it's not a good question. It's just a hard thing to imagine. You know, you have to look into the future. You know, if there was some test you could do, I don't know, some clever test that we can't even think of. I mean, who thought of PCR before someone thought of PCR? Now everybody knows, because of COVID, everyone knows what PCR is. You know, everyone knows the PCR test. But you know, when I was doing my PhD, PCR was like brand new, right? I mean, you know, PCR was a big thing. The guy got the Nobel Prize for it. It was a big thing. But before PCR, like, there was no PCR. So who knows? It could be possible in the future, but not right now.
Perfect. So we hit the 3 o'clock mark.
Yeah,
we did it, guys. If there is any more questions, you guys feel free to message us, send us an email at SCCOHT. We are still recruiting now and always for the registry, so if anybody wants to join and help our cause and like learn more, maybe we'll find and create a test here someday for
and to give us some feedback to Melissa via the Facebook live contact. You know, what do you think about this format? We've never done it before. We had those of you who've looked on the website have seen the Zoom talk we did with a bunch of people. This is the first time we're doing more, like I said, one-on-one. If you think it works, if you think it's interesting, and you think you got value from it, then we could do another one. I mean, Sid and I have the advantage of being in Montreal. It would have to, if it was with Amit Oza or with Joe, it would have to be probably via you know,
Facebook Live still.
Facebook Live screens, we do the same thing, but we're not side by side, which is nice. But let us know what you think. If you think it was worthwhile, we could do another one. You know, and we'll put this on the web. We'll put it on the website.
It'll be on the private Facebook group. It'll also be on our website.
Great.
And Maren will be sharing it as well to her website.
Yeah. So let us know what you think. Give us some feedback if you think it's good, and if you have specific people or topics you'd like me to, I'll be sort of like the anchor and then interviewing other people. So if there's people you'd like me to interview and to talk to, then let us know and we'll do our best to meet the needs.
Yeah, help us pick our next guest.
Yeah, all right, pick your guest. Okay.
Bye, guys.
Thank you.
Thank you.
Bye-bye.